I'm here today with Dr. Wissam Jaber. Wissam is Cath Lab Director and Interventional Fellowship Director at Emory University. Thank you so much for joining us today.
Sean, thank you for having me.
So we're here at ACC in New Orleans, and we just watched together the FLAME data being released. And having you here is really spectacular because you've sort of been dealing with this disease state since its infancy in terms of at least interventional cardiology involvement. And so I'd love to hear your perspective on sort of where we've come from to kind of get to a point where now we're finally starting to see prospective data being released in the field.
Yeah, I think, Sean, this is really exciting. I mean, I'm one of the people that have witnessed the progress in this field for a long time. This is starting around 2012 when I became interested in this, and PE treatment at that time, all we could think about was catheter-directed lytics, and this was the only thing on the market or in our pocket we could treat those tough patients, And treating PE population is really exciting because it's a population that has been treated the same way for a long time. So for me, trying to find a way to treat these patients better, as a cardiologist, we've been trying to do that for every other disease for a while. We've done it for coronary disease, for stroke treatment, for a lot of other diseases, but in pulmonary embolism, it seems that the guidelines did not want to change. It seems that things were stuck where everybody is treated the same medical way, and so it was really about time to come up with something new, with devices, with something that helps these patients. And the excitement at that time in 2012, 2013 was mostly around catheter-directed lytics. And it's funny to remember that and see how it was for me to kind of put a catheter in the lungs, such a foreign concept, and the clot in the lungs. And I was very excited learning that in the cath lab and very nervous doing it on patients. And eventually we realized that we were, in fact, helping these patients doing catheter-directed lytics. And I believed in that therapy. And also I believed in gathering more data on these patients. And so we started registries and amassing data. I remember very clearly two patients of mine that had, in maybe 2014, 2015, I cannot remember the exact date, but I remember very well having two intracranial bleeds with catheter-directed lytics. So yes. I was in my mind, I was helping these patients, and one of them was really sick, was a massive patient, and one of them was not that old, was 68, one was 75, and that always makes you pause and like, are we really? It makes you, as an interventionist, makes you not sleep at night and make you think, well, I did this, I was trying to help the patient, but it wasn't helped well, and that always pushed me to try to find a lytic-free treatment for these patients. We've also seen patients getting systemic lytics and having DIC from that, or having intracranial bleed, or having massive bleed elsewhere. So we clearly need an additional treatment. And I can't remember the year, maybe 2015, when the early guys from Inari stopped by at Emory, and there was barely any clinical cases done, human cases done on FlowTriever, and the prototype was the 20 French with the discs in the past, and the thought was to have the discs pull the clot back into the catheter. And we were very excited, and we didn't understand exactly how things worked at that time. And to pull the clot towards the catheter is what we thought would be the treatment of choice in these patients. We didn't understand how much suction we need to do, and it was all something. The exciting thing about it at that time was that we were all learning together how to treat these patients, how to do catheter therapy, and we just picked it up. I thought this is something that actually can help the patients, and I was disappointed, to be frank. The first three cases is because I was doing it wrong, and that's the nice thing about it is that you learn how to actually apply the technology the right way, and once we started kind of getting closer to the clot, getting the catheter down, once we started exerting enough suction and that whoosh thing in the back of the catheter, we realized that actually there's something more to this, and we can help patients more, and then more and more clots started appearing, and it was exciting to show these at that time. Now it's all over Twitter, as you know. So it's, it's not as exciting as it used to be when we see the clots. But what's exciting about it, so what I meant is the picture of the clot is not as exciting because we see them all the time. But what's still very exciting is how quickly these patients improve. And no question that it's really encouraging for us to keep going and keep looking and keep improving the therapy and keep improving patient selection. And I think the therapy is really good at this time. We're more into patient selection, and we got all through to the point now that we saw today the FLAME data being presented.
Yes.
And that's super exciting. That's even more exciting to me lately than what I've seen in the submassive population, because this is the population that traditionally has been underserved. But to serve the patients, this massive patient population, it's hard to say, well, I only want to treat the massive patients with catheter therapy, because you're not going to pick up that catheter and work on a patient where you're not comfortable using the catheter. So to treat patients with thrombectomy, be very comfortable treating the submassive, the intermediate risk patients with catheter, makes us very comfortable treating the really sick patient that has 30 and 40% mortality with a catheter. And Silver has demonstrated that very nicely today with the FLAME, that we actually can.
Yes.
We can, and people who are used to using the FlowTriever catheter in the submassive population, when they take on the massive patient population, I'm convinced we're saving lives. So we are making a big difference, and that was clear in the data.
You personally have overseen and led a lot of the efforts, the largest data collection efforts in the field with regard to catheter-based embolectomy and thrombectomy for this disease state. And you've seen a few evolutions take place. I really liked your narrative of, we start with an early stage device, we learn the best practices, we iterate the device, then we get to the point that we launch RCTs and take those learnings and implement them so that this new technology can benefit patients. One of those big innovations that took place during the FLASH registry data collection was FlowSaver, was blood return. Talk to me a little bit about FlowSaver and how it's changed things, and even in the FLAME registry, how you see that making an impact.
Yeah, that's a good point. Now it's such a common thing to use that I didn't think about it. I think it made a big difference, because when you ask people when do you stop when you do thrombectomy, and most people answer, well, when I've pulled too much blood that I'm not comfortable pulling anymore. Mm-hmm. And I heard that in one of the sessions today, and some of the commentators saying that. But with the FlowSaver, it really practically gives us a freedom to keep going at the clot without thinking that we're going to be losing a lot of blood. So with the FlowSaver, that's not part of my algorithm anymore. Mm-hmm. It's not like how many times I've aspirated or how many times I've gone after something. My algorithm now is purely patient-driven data, how well the patient is getting. If I've removed enough clot, the patient is doing better hemodynamically, that's when I stop. It's no more blood loss. And I really believe that made a big difference there. And that compares favorably with other devices where continuous aspiration, it's really very hard to control the blood loss. And that's why I believe that the Inari technology in that sense is better than the continuous aspiration devices because of this blood loss. It doesn't matter how much you work on reducing that, it won't match it. The other things with changes when it comes to with the FLASH data and patient is obviously the bigger catheter, and then we had the 16 flange, and then we had the curve catheter,
yes.
the T20 curve. And I have to say something, Sean, and I've said it early on, from an Inari company standpoint, the reason I was excited personally working with Inari is the ease of feedback and the changes that the company was making. And I'm really being very frank about this, is that the team, the engineering team and the leadership there was truly interested in advancing the technology and not just selling any technology. And that's clear in terms of how quick the feedback went back to the company, how quick the engineers incorporated the feedback from the physicians, hence the unusual iteration of changes in the device that you don't see in the industry. Most devices that we've seen in industry come with maybe one catheter, and then it's going to take years until you change something, because it's not easy. There's a big process that you have to go through, a regulatory process, engineering process, and Inari was willing to do that, to improve the technology, and we saw that. We saw the feedback, we saw the changes when it comes to improvement in the device, from the 20 to the 24 to the curve to the 16 to the change in the disc. to the large bore syringe aspiration, to the change of the whole mechanism. I mean, all these are many changes that the company had to go through, utilizing the feedback of the physicians.
Yes.
And,
Yeah.
and that's something that really does not go unnoticed, and that makes us want to work with the company more. And I'm very excited, and I'm pretty sure that the company is still interested in making whatever changes every time we discover that, well, if we do this a little differently, we're going to have better clot aspiration, safer procedure for the patients. It seems that the company is interested in doing that.
I share your admiration, honestly, for that innovative spirit. The idea that the goal here is optimal patient outcomes, and it's possible that your baby is ugly and needs to change, and there doesn't seem to be too much consternation to take input from people like you that are out there that are doing this procedure, that see the outcomes. Let me get you on this question. Today was a big leap forward from a scientific standpoint for the field. An enormous leap is coming, and that will be the result of the Peerless study. So tell us a little bit about that study and what you're looking forward to upon its completion.
Yeah, Peerless study is another very exciting thing. I mean, we saw today the FLAME data, but the Peerless is an additional piece in that big puzzle that we're trying to put in there. Because what we frequently hear is that, well, interventional treatment of pulmonary embolism is the same, but I don't think it's the same. We don't think it's the same. So it's good to advance the field by understanding what catheter does what treatment does what. And if you look around in practice, different people do different catheters. And I heard it today in one of the sessions where the majority of the partners in a practice do catheter-directed lytics because it is easy and it doesn't take as much skills to get it up in the lungs. Although in my mind, what we're missing here is what's easy for us in the lab. It may not be easy for the patient afterwards, and we're not always in the business of doing the easiest thing. We're in the business of doing the safest and best thing for the patient. So if it takes us a little extra effort to learn a different procedure than the one procedure we're comfortable with, I think we should do it. But we need convincing data first, and this is where Peerless comes in. So Peerless is asking the question, is it better for these patients to use flow retriever thrombectomy or use catheter-directed lytics? And that answers a question that's out there in the community. Looking at real outcome that mean for the patients, we're not looking at just RV to LV ratio, as you know. We're looking at mortality, we're looking at intracranial hemorrhage, at major hemorrhage, we're looking at ICU stay, and we're doing it hierarchically and realizing that the most important outcome is, for example, mortality, and after that is intracranial bleeding. So we're really following what's important for the patient and for the clinician and for the community, and that's going to be great, and that's going to complement the other data that's been gathered. Obviously, there are other trials being done, and this will fit nicely with, for example, the result of the HiPytho trial, looking at the catheter-directed lytics versus anticoagulation. And so the more data we collect, and the more support we have from industry like NRE for these very important data, the better the field is going to move forward. And at least this is very exciting, because if you just study what trials have been done and what's been poured into PE in the last few years and compare it to what's been poured into PE in the last several decades, it really dwarfs that, and that's what's exciting about this.
Wissam, thank you for the time, thanks for the expertise, and thanks for what you're doing for patients and for the field.
Excellent. Thank you very much for having me.